tape up, do you?
Yes, I do.
Just put a little piece of tape on it. Good.
calculated documents or expected cash or even to pay a college.
What are you looking for? Yes. I don't have it with me, but thank you for being here.
Thank you for having me.
That's what we came up with.
Nice to be here. I enjoyed last summer.
I remember you guys. I was actually on the phone when we were talking.
That's a lot of work.
I couldn't access the phone call. I don't know. I still haven't figured out. I think it may have something to do with the Verizon strike. I don't know.
I didn't know there was a Verizon strike.
In Long Island, they're on strike, which may end shortly. I don't know.
Yeah, everybody else is going, so if you just go straight down the hall. It's
I
like,
wonder how the breaks are here.
all right.
Do we have a need to go to the bathroom?
You can't go until the break.
She's in the bathroom.
So
If you
here's
want to
the
go to
break.
the restroom, that's
10
fine.
o'clock is the first break.
Yeah, that's what I'm saying. She was asking because she goes to the bathroom.
You can't. I don't think you're going
If I should go now?
Well, she's the first
Everybody
presenter.
else did. That's why they're not here.
Where is it? Where is
You
it?
need to
Down the hall to your
right now.
They are working on getting it now, but
Yes.
CMS and all that. CMS and all that. The word death, capital G, is all one
Looks
word.
like I'm the only guy who brought stuff.
No, I have stuff in my bag. Actually, I don't want you to feel.
You know, I love bringing stuff. I mean, what would I do without my stuff?
You can scan it all in on your phone.
We have Wi-Fi.
We do.
And then 2016.
I'm still trying to connect to it. So let me
Yeah, I
tell you,
tried
it's not-
connecting and it
It's very
didn't work.
frustrating, and I apologize. If I were in charge, I'd connect.
I know you would, you know.
Because I find it just as frustrating.
It is. It's very frustrating. But I connect to my phone.
Yeah.
You know, that's what I did.
I'm a
No
cheap
space.
though, because it's close to my
Yeah,
dad's
with-
limit, and I don't want to pay anything extra.
Oh, jeez.
Go for it.
you're
Don't
one of
forget
those.
your folder.
Well, I tell my kids.
I'll
you know,
hold
we
it.
get 5 gigs, you know.
So you won't forget it.
3 kids, and I monitor every week, and I say, okay, Harry, cut back, you know, so we don't go over.
Yep. Mine
Do you-
are really young. Yeah.
Yeah.
Dr. Cuyjet, do you need the password?
Well, I have 21-year-olds, and they love data.
I bet they, I know they do.
Oh,
That's all they do.
they love data, you know, and I have to rein them in, you know, because one bite over is $30.
So you're not at CES, just like I monitor. I'm getting close.
Oh yeah, no, every week.
Well, I have.
Every week I
I
check.
have Wi-Fi. I print out some. Oh, no, I don't know the password for Wi-Fi. Is there a password?
Did you pass it out? Because I tried this morning. Yeah, the CMS and then 2016 or something. Yeah, I did.
What it?
Yeah, and then G, yeah. Right. Yeah, and then in welcome is the user.
MEDCAC.
No, what is
Guest is in caps too.
No, what is the username though? Let me see.
And then capital W.
Yeah, that's the password.
Capital W. And then everything else goes to wireless.
Oh.
And then 2016.
Yeah, but
IR is capital too. IR. It's wireless.
It's just wireless. No, that's not capitalized.
Okay.
And then 2016.
But what is the username?
So, like, I'm going to turn it on.
See, because that was the problem. Yeah, I mean, because I put all this in and it didn't work.
Oh, well, it's pretty simple.
I bring archives, I never know.
Okay, forward, backwards, time remaining, they'll let you know. So, and then time's up. This is a warning, and I think it's a 3-minute warning, but they'll tell you. I've got plenty of time, but don't tell anybody that, okay? Alrighty, but then slide forward, or here you go, forward, back, whichever one, okay? Dr. Trivedi. Forward, back.
Am I on?
Time remaining. There's
Great.
a
Can I ask you to
warning
take your seats,
light.
please?
Time's up. But you have, trust me, plenty of time. Okay. Is there a time? We'll find it.
Good morning and welcome Acting Chairperson, Acting Vice Chairperson, members, and guests. I am Maria Ellis, the Executive Secretary for the Medicare Evidence Development and Coverage Advisory Committee, called MEDCAC. The committee is here today to discuss recommendations regarding the definition of treatment-resistant depression, TRD, and provide advice to CMS on the use of the definition of TRD in the context of coverage with evidence development and treatment outcomes. The following announcement addresses conflict of interest issues associated with this meeting and is made part of the record. The conflict of interest statutes prohibit special government employees from participating in matters that could affect their or their employer's financial interests. Each member will be asked to disclose any financial conflicts of interest during their introduction. We ask, in the interest of fairness, that all persons making statements or presentations disclose if you or any member of your immediate family own stock or have another formal financial interest in any company, including an internet or e-commerce organizations that develops, manufactures, distributes, and or markets consulting, evidence reviews or analyses, or other services related to treatment-resistant depression. This includes direct financial investments, consulting fees, and significant institutional support. If you have not already received a disclosure statement, they are available on the table outside of this room. We ask that all presenters please adhere to their time limits. We have numerous presenters to hear from today in a very tight agenda and therefore cannot allow extra time. There is a timer at the podium that you should follow. The light will begin flashing when there are 2 minutes remaining and then turn red when your time is up. Please note that there is a chair for the next speaker, and please proceed to that chair when it is your turn. We ask that all speakers addressing the panel please speak directly into the mic and state your name. For the record, voting members present for today's meeting are Dr. Harry Burke, Dr. Aloysius Cuyjet, Dr. Salvador Cruz Flores, Dr. Roger Lewis, Dr. Gail Malkus, Dr. Daniel Ollendorf, Dr. Thaddeus Pope, Dr. Marcel Salive, and Dr. Jufen Yan. A quorum is present and no one has been recused because of conflicts of interest. The entire panel, including non-voting members, will participate in the voting. The voting results will be available on our website following the meeting. I ask that all panel members please speak directly into your mic. This meeting is being webcast via CMS in addition to the transcriptionist. By your attendance, you are given consent to the use and distribution of your name, likeliness, and voice during the meeting. You are also given consent to the use and distribution of any personally identifiable information that you or others may disclose about you during today's meeting. Please do not disclose personal health information. In the spirit of the Federal Advisory Committee Act and the Government in the Sunshine Act, we ask that the advisory committee members take heed that their conversations about this topic at hand take place in the open forum of the meeting. We are aware that members of the audience, including the media, are anxious to speak with the panel about these proceedings. However, CMS and the committee will refrain from discussing the details of this meeting with the media until its conclusion. Also, the committee is reminded to please refrain from discussing the meeting topics during breaks or lunch. If you require a taxi cab, there are telephone numbers to local cab companies at the desk outside of the auditorium. Please remember to discard your trash in the trash cans located outside of this room. And lastly, all CMS guests attending today's MEDCAC meeting are only permitted in the following areas of CMS single site: the main lobby, the auditorium, the lower level lobby, and the cafeteria. Any persons found in any area other than those mentioned will be asked to leave the conference and will not be allowed back on CMS property again. And now, I would like to turn the meeting over to Tamara Jensen.
I just wanted to publicly thank the panel for coming today on this very important topic. But in an effort to get us back on time, I'm just going to end with that. And I also want to thank everyone who showed up today as well. Thank you.
Yeah, same for me. Thank you all for attending. Thanks to the panel for your participation. We're looking forward to an interesting, active discussion. I'm going to get started with Linda. If you want to go up and read. Linda Gousis, who's going to read the voting questions and give a brief presentation on today's topic.
Good morning. I'm Linda Gousis, a technical advisor in the Division of Medical, Surgical, and Surgical Services in the Coverage and Analysis Group. My role here today is to read the purpose of the MEDCAC and to read the questions into the record. So let's begin. The purpose of the meeting today is to obtain the MEDCAC recommendations regarding 1, the definition of treatment-resistant depression, abbreviated as TRD. 2, advise CMS on the use of the definition of TRD in the context of clinical studies, coverage of evidence development, and treatment outcomes. Voting question number 1. How confident are you that there is a standard definition of TRD that can be applied to Medicare beneficiaries in clinical studies of therapies for this disease? Use the following scale identifying your level of confidence, with a score of 1 being low or no confidence and 5 representing high confidence. Voting question number 2. If intermediate confidence, greater than or equal to 2.5, is noted for question 1, please vote by yes or no as to whether the following are important defining characteristics of TRD that are to be considered in clinical research. A, the number, duration, dosage, and/or classes of antidepressants attempted. B, the use of augmentation/combination pharmacological therapies. C, type of depressive episode, unipolar, bipolar, psychotic, atypical, other. D, the use of non-pharmacological treatments, such as electroconvulsive therapy. E, the use of psychotherapy. F, score changes on standardized and validated depression rating instruments, for example, the Hamilton Depression Rating Scale. G, suicidal ideation and suicide attempts. H, other. Voting question number 3. If intermediate confidence, greater than or equal to 2.5, is noted in question 1, how confident are you that this definition can be applied to Medicare beneficiaries? A, in primary care settings. B, in general psychiatric settings. C, in specialty psychiatric settings. Use the following scale identifying your level of confidence, with a score of 1 being low or no confidence and 5 representing high confidence. Voting question number 4. How confident are you that each of the below is a reliable, valid, and meaningful health outcome for Medicare beneficiaries in a clinical study on TRD? A, improvement or decline in function. B, improvement or decline in quality of life. C, decrease in suicide ideation. D, decrease in suicidal attempts. E, other. Use the following scale identifying your level of confidence, with a score of 1 being low or no confidence and 5 representing high confidence. Question number 4, discussion item. For each characteristic in question number 4 that receives intermediate confidence of greater than or equal to 2.5, please discuss the a priori parameters that define successful or failed treatment. Again, the characteristics listed in question 4 were A, the improvement or decline in function, B, improvement or decline in quality of life, C, decrease in suicide ideation, D, decrease in suicidal attempts, E, other. In voting question number 5, how confident are you that the strategies below, when applied to Medicare beneficiaries, represent meaningful and realistic study designs in research investigations performed to evaluate interventions for TRD? A, randomized sham-controlled double-blind trial. B, randomized sham-controlled single-blind trial. C, randomized controlled unblinded trial. D, randomized crossover study. E, non-randomized crossover study. F, pre/post study design. G, other. Again, use the following scale identifying your level of confidence, with a score of 1 being low or no confidence and 5 representing high confidence. And that concludes the questions. Thank you. Dr. Bach?
Yes, thank you very much. I'd like to now have the panel introduce itself. We'll go down the row, and with as each of us introduces ourselves, we will state what our conflicts are. Those are also publicly available. I'm Peter Bach. I'm the acting chair today. Although I'm the vice chair of this body, I have no conflicts to disclose.
I'm Al Cuyjet. I am acting vice chair, and I have no conflicts to disclose.
I'm Harry Burke, and I'm not acting anything. And I have no conflicts to disclose, and the views I express are my own, do not represent the federal government, Department of Defense, or Uniformed Services University of the Health Sciences.
Salvador Cruz, Flores neurologist. I have no conflicts to disclose.
Roger Lewis from the Department of Health Services in Los Angeles County. I have no conflicts to disclose.
I'm Gail Duramo-Melkis. I'm an Associate Dean for Research at NYU College of Nursing and an adult primary care nurse practitioner, and I have no conflicts of interest to disclose.
Dan Ollendorf with the Institute for Clinical and Economic Review. No conflicts to disclose.
Thaddeus Pope. I have no conflicts to disclose.
Marcel Salive. I'm from the National Institutes of Health, representing myself, and I have no conflicts to disclose.
I'm Evelyn Yan from University of Virginia. I'm a statistician involving designing clinical research study.
I'm Ted Listig from Medtronic. I'm an employee and shareholder there. I'm the industry representative.
Will Carpenter, a psychiatrist, professor of psychiatry at the University of Maryland School of Medicine and the Maryland Psychiatric Research Center, and also part-time with NIMH. I have conflicts that relate to occasional consultation on clinical trials to industry. None of them involve the subject matter of today.
I'm Brad Gaines, a professor of psychiatry at the University of North Carolina, and I have no financial conflicts to disclose.
I'm Carlos Rowdy from the National Institute of Mental Health. I'm chief of the section of neurobiology and treatment of mood disorders. As it pertains today, I don't have a conflict of interest. Other disclosures are that I am a U.S. federal employee. I have a patent on the use of ketamine in depression with the U.S. government.
Thank you very much. The first part of the morning is 2 formal presentations of 45 minutes each. In your agenda, you will see the speakers listed, although they're actually going to present in reverse order. So if we could ask Dr. Madhukar Trivedi to come. Dr. Trivedi is a professor of psychiatry, the Betty Jo Hay Distinguished Chair in Mental Health and Director, Center for Depression Research and Clinical Care at UT Southwestern. Thank you very much for coming today.
Good morning. Thank you very much, and I'm excited to be here. This is an important topic, and just a quick sort of my personal view on this. we have, for the longest time, I think depression was treated as if it is an episodic illness that can be easily treated. I think the last 15 years of research has convinced us that this is a very complicated, very heterogeneous disorder, and it is much more complicated to treat, leaving a lot of patients at least not improving with the current treatments we have. So this topic of treatment resistance is very important, and hopefully we'll get into all the details. I have consulted with various industry sponsors on antidepressant treatment development, both pharmaceutical as well as devices. Although I'm not really going to talk about treatment per se today, I'm really addressing the issue of what is treatment resistance and how best should we think about defining it. Thank you. So I'm going to address the issue of how big is the problem? Is this a small proportion of patients with major depressive disorder, bipolar disorder? Is it a larger proportion? What is the impact, both in terms of healthcare costs, suicidal ideation, suicide attempts, suicide, and what are the ways people have really tried to grapple with this idea for definitions? There is actually some debate and discussion to be had about the exact definition, and hopefully I'll try to clarify it towards the end of the presentation. So depression is very difficult to diagnose, as I mentioned earlier. We do not have a lab test, and therefore I think hence this part of the debate. So lab tests are not available for major depressive disorder or any form of depressive disorder overall for diagnosis, leave alone for subtypes, or for that matter, treatment resistance. And so therefore, we have to be thinking about how best to diagnose patients based on symptom history, treatment history, as well as other pertinent information in terms of medication use, substance use, etc. All of those factors will have to be thought about as we start defining what is treatment-resistant depression. We do know that only about a third of the patients will get to remission with the first antidepressant medication. Numerous studies have shown that. I'll also describe a little bit from a large trial that was funded by the National Institute of Mental Health several years back. About 29 to 46% of patients will not respond to pharmacological therapy even after adequate dose and duration, which is the key issue that one must think about when you want to define treatment resistance. Just a quick word on that. There are many medical disorders where we define severity or poor prognosis based on the disease itself or on the pathology or on biopsy, etc. In treatment-resistant depression, unfortunately, some of it is circular, as you can imagine, because somebody has to have failed to do well on several treatments before you define them treatment-resistant. You cannot actually and generally end up being able to define it earlier. And therefore, this idea of whether people have gotten adequate dose and duration of each treatment becomes key in defining treatment-resistant depression. The bottom line is still clear that even after a patient has been tried on multiple treatments, medications, augmentations with medications, psychotherapy, exercise, any treatments that have been accepted by the field, even after having tried several of these at an adequate dose and duration, there are a sizable proportion of patients who remain symptomatic and do not have full recovery in the short term. Again, in the long term, these numbers are actually likely to be higher. We suffer in our field from not having large-scale, long-term follow-up cohort data in order for us to know. But even this group of patients who belong to the non-25% who do well from time to time, if you look at their outcome in the long term, the numbers are actually worse. So there is no accepted universally accepted definition. Part of it is, I think, that more recognition increasingly that this is a much more difficult to treat disease. So that 20 years back, only if you had failed to have many treatments and also or with ECT, you would start calling that treatment resistant. I think we're beginning to recognize that if you wait that long, you're missing a whole chunk of group of patients for whom third, fourth, fifth, sixth treatment steps may not be accruing additional benefits. So therefore, we have to revise, revisit how we want to define treatment resistant. Most current definitions still continue to talk about it that treatment-resistant depression is a group of patients who have failed to do well on multiple treatments that have been given with adequate dose and duration. However, with the results coming out from several trials, including the STAR-D trial that I'll talk about, we are beginning to recognize that after first two treatment steps, the benefits that patients you get in terms of third, fourth, fifth treatment trials are very small, and therefore, after the first two treatment steps, whether we should be calling that treatment-resistant depression or not is an area of question and debate, and I'll try to address what different groups have tried to talk about in terms of this definition. There is no debate about whether if after somebody has not done well with 5, 6 treatments or 10, 20 treatments that this is treatment-resistant, obviously, but that is sort of not very clever for us to really call it treatment-resistant, because if somebody is not done well on 20 treatments, it's anybody's grandmother can define that as treatment-resistant depression. So the question is how well and how soon and how precise can be early on in order to make a difference in people's lives, both in terms of healthcare costs, in terms of suicidality, etc., is, I think, where we have to be going as a field. As I mentioned, keep on mentioning, two key elements remain: adequate dose and duration. That has to be defined, and partly that is because there's a sizable proportion of patients, when given an antidepressant, do not actually follow through on that, and so we have to first define that before you call somebody treatment-resistant. You also have to obviously do differential diagnosis, ruling out other comorbid conditions, other factors that may be associated with poorer outcome on any given antidepressant treatment. So this question of dose duration and adherence to treatment remains a big cardinal issue, and before we start defining a group of patients as having a severe enough disease that our current treatments may not be the best. And that is inadequate dosing is often a big problem. Early discontinuation, partially because patients recognize they have side effects and there is not enough patient education, there's not enough collaborative care being delivered, and therefore patients are less educated about the need to continue or at least go to the next treatment step. Atypical pharmacokinetics, there may be patients who have rapid metabolizers of certain drugs or slow metabolizers, etc., will determine adverse events and therefore their adherence to treatment. And then misdiagnosis, especially if there is a misdiagnosis in the setting of other chronic medical diseases, substance use disorders, etc., remains also an issue that needs to be addressed before somebody's depression should be thought of as resistant to treatments. Depression is obviously chronic, and patients remain non-adherent. So chronic nature of the depression, in the collaborative care depression study, one of the long-running, large originally NIH-funded studies, where patients were followed up to 12 years, and you can see that only 27% of patients did not have even a single asymptomatic week during that study. So this population really clearly helps us understand that there is a large proportion of population that does not do well, and doesn't do well at all actually in this study, that has to be addressed and not be seen as a normal outcome of the disease. So prevalence of treatment-resistant depression remains something that people always question, so even in primary care. So most often when somebody thinks about treatment-resistant depression, we all think of these patients as being seen in psychiatrists or psychologists' offices. That is not always true. So this is in a primary care population in the UK, and you can see of this 2,439 patients who responded, 37% had minimal or greater depressive symptoms even after 12 months of antidepressant medication treatment. So there is, again, a group of patients, even in primary care, that remain symptomatic despite treatment. This is from a Canadian study. This was based on a case reports filled out by physicians and over 1,000 patients. They defined failure to respond to 2 antidepressants, and they have 27% of patients had treatment-resistant depression. The features of these are, again, very common and similar to what other studies have shown. Patients who have not responded to several treatments end up being those who have early age at onset, those who have had chronic episodes of depression, those who have had early life trauma, those patients who have associated significant comorbid medical conditions, associated significant anxiety symptoms, are the kinds of patients that remain resistant to current treatments. The risk factors for treatment-resistant depression, as I mentioned, actually are listed. Some of them already include comorbid anxiety disorder, suicide risk, melancholic features, bipolarity. Bipolar disorder, actually, in the setting of treatment resistance is an important issue that needs to be addressed, and differential diagnosis that requires understanding whether this is unipolar depression or bipolar depression is also often not paid attention to. That needs to be seriously considered. And then the same things I mentioned, early age at onset, etc. Healthcare costs for treatment-resistant depression have been very easily seen to be significantly higher than the healthcare costs for patients who do not have treatment-resistant depression. And in this large economic study based on a very large cohort, you can see about 24,000 patients were defined as treatment-resistant depression, and their costs were quite significantly higher than those who were not resistant. Healthcare costs for TRD, another study showing that even after you adjust for other factors, about 30% of the cost or the cost is about 30% higher for treatment-resistant depression than for non-resistant depression. So healthcare costs are higher for patients who have treatment-resistant depression, and there are many factors. Obviously, the cost of the treatment itself, but the cost to society is something that we have to be paying attention to. So you can see this data showing that about $4,000 in terms of lost productivity is associated with treatment-resistant depression, and the annual healthcare costs are about $5,000. Same thing is repeatedly seen that the more treatment-resistant the patient's illness is, the higher the healthcare costs, both direct as well as indirect costs, are routinely seen. The one other important factor that we have not really paid attention to as a field enough is the rates of suicide in this population. Suicide rates clearly something that we have to be considering for patients who have treatment-resistant depression. As you saw in the collaborative study, that there's a sizable proportion of patients who do not ever have asymptomatic week. That means there is a longer duration of exposure for them to have suicidal ideation, suicidal attempts, and unfortunately suicides. And recent data are showing that suicide rates are not decreasing. If anything, they're increasing in the United States. So about 17% here of patients with TRD reported prior suicide attempt. Again, that is a very large burden for both the patient, their families, and society coming from treatment-resistant depression. So how do we define treatment resistance? As I started the conversation, there is some debate, and let me sort of also clarify with this debate first, and then I'll give you what other people, different groups have really used to define treatment resistance. The debate actually is not that whether or not resistant depression exists. That is clear. I don't think, and I showed you the data, I can show you more. The debate actually in the field these days is whether we should wait for 5-6 treatment failures, whether we should wait for failures on different things like electroconvulsive therapy or other treatments before you declare treatment-resistant depression, or like we do in general, all medical illnesses, should we start thinking about segregating patients for whom the risk for treatment resistance is earlier on so that our interventions can actually be matched to patients? That is what we have not done, and I think the debate really primarily revolves around how best to start thinking about it. And, and I'm not going to sort of tip the scale in terms of my opinion, but I think that is really the issue in the field. And so people have used medication failure method, where you define the category of whether the patient has treatment-resistant depression or not, yes or no, or there is degrees of failure, is how other people have done. That is the staging model. And there are many groups that have attempted to do this by fine-tuning the methods. I think John Rush and Michael Thays described this in the early 90s, and strategically, most other groups have really sort of modified that a little, but really the basic principles still apply, and I'll go through that and then give you some idea of the other methods people have used. So this is the original method that Thays and Rush used to define. This is really when SSRIs and tricyclic antidepressants and the monoamine oxidase inhibitors were the primary antidepressant medications available at that time. And then as other treatments started coming along, like the selective serotonin norepinephrine reuptake inhibitors, they also modified their definition a little bit. So the first was stage 0, any medication trial determined to be inadequate. Stage 1 is if they have one antidepressant trial of one major class. Stage 2 is failure on 2 adequate trials, 2 distinctly different classes. Originally in the 90s, and then even in the early 2000s, they and others actually meant this to include an SSRI here and an SNRI here would be something that you can count. Recent data are really beginning to question whether there is that big difference between the second step SSRI versus a second step SNRI, suggesting that it is really not that precise. But the point being 1 adequate treatment trial, 2 adequate treatment trial, and then really thinking about adding a tricyclic antidepressant, although again the data supporting the sort of strength of this evidence as a third step over some other treatments. There are very few studies talking about it. And then the 4th treatment stage failure is monoamine oxidase inhibitors. This made pharmacological and logical sense, not necessarily all based on pristine, well-controlled clinical trials that would have randomized patients to after 3 treatment failures to a monoamine oxidase inhibitor versus something else. So therefore, this really was meant as a guide, and that definition or that approach to defining treatment-resistant depression, in general, still really holds. People had misunderstood by calling this only resistant when patients have had 4 treatment failures. But if you really carefully understand this, they are actually talking about treatment resistance starting early on, and then you have to decide how severe the treatment resistant form of this depression is, so that a patient here can and should be seen as resistant, but that there might be people for whom tricyclics are what they were recommending. The Mass General approach is very similar to it, although they focus a lot more on the adequacy of the dose and duration of the treatment exposure. And there are 2 major approaches at documenting the level of resistance. One is the Mass General Hospital has a questionnaire called ATRQ, it's antidepressant treatment. And then the other is the Columbia Group has used a questionnaire for a very long time, again defining the exact clarity of how well the antidepressant was delivered in the patient's past. that talks about dose, duration, and adequacy of the treatment trial, really defining whether somebody had 1, 2, 3, 4 treatment failures. How best to then define the addition of an augmentation agent that is not itself an antidepressant treatment, medication or psychotherapy, etc., is something that both the MGH approach and the Columbia approach try to account for. The European method really, again, builds on the same thing, a non-responder to 6 to 8 weeks of traditional antidepressant treatments, but they include any of these, including SSRIs, ECT. And then there is a staging of treatment resistance. That is 1 treatment trial, 2, 3, 4 treatment trials approach. And then if that is for over 12 months, they call it chronic resistant depression. This is the European method of defining treatment-resistant depression. Again, similar models, similar logic, but this method tends to actually also emphasize the duration for which somebody has remained resistant. The Maudsley method is slightly more sophisticated in terms of trying to figure out scoring based on the kinds of treatment exposures patients have had, all trying to figure out if it is really stage 3 treatment resistance or 3.5 treatment resistance, but again, not any profoundly different in terms of the principles they use. So, the question and the debate that I was talking about is, should this staging that was brought out by Michael Theiss and and John Rush in the early 90s continue to be the same approach, or should we start thinking about whether at the end of 2 or 3 treatment steps with current antidepressants, we have now arrived at a point where the patient's history defines them as a group of patients who are at higher than high risk for resistant depression, and therefore requiring or needing special attention by way of assessments, treatment, etc. I'm not going to go into the questionnaire, but this is the kind of thing, just to give you an idea of the questionnaires that are used in order to define exactly the nature and the precision of the antidepressant treatment trial. So, bottom line is, at the end of the day, our goal, in order to ensure that somebody has been getting adequate treatment before they, sort of in the early phases, so that we can then pay extra attention or special attention to patients with treatment-resistant depression, would require that these 4 steps be thought about as a treatment is started. So any given antidepressant treatment trial is started with medication psychotherapy, it doesn't matter what treatment, should be fully optimized in order to A, give the patient the best chance of success, and prospectively, eventually, when we end up with a subgroup that requires additional attention, we have actually good enough confidence that they had good trials. And if the optimized treatment does not lead to outcomes, then you have to think about whether they should be switched, whether a combination should be used, or an augmentation agent to be used. For the purposes of this discussion and overall in general in the literature, when somebody talks about combinations, is 2 antidepressants that individually have been seen as antidepressant in their action. Augmentation is an augmentation agent that itself is often not seen as an antidepressant, but when added to the antidepressant treatment, medication psychotherapy, augments that effect. And lithium comes to mind as a classical augmentation agent. So, a few words on the study trial, and then I'll stop. So the sequence treatment alternatives to relieve depression was in fact, the largest clinical trial still conducted in terms of efficacy for antidepressant treatments. It was designed to answer this kind of the real-life question. It was done in real practice, primary care and specialty care settings, 4,000 patients, where patients were really entered into the study with the assumption that we will try to address the question: if the first treatment does not work, what is the second best treatment? If the second doesn't work, what is the third best treatment? If the third doesn't work, what is the fourth best treatment? This was done started in the late 90s and finished in 2006, had been primarily with medications and psychotherapy, or only medications and psychotherapy. And what we found is that at the end of first step, remission rates are about 30%. At the end of second step, remission rates are close to it, 25 to 30%. But the remission rates at third and fourth treatment steps dramatically drop. And this is where the question of whether you should start thinking about the group of patients at this point as people we should be thinking about differently. There was some distinction in the STAR-D trial, and let me take a minute to walk you through this. If patients, this was citalopram, if patients had not done well on citalopram, they could be switched to a second antidepressant medication or psychotherapy. So there were 3 antidepressant medications and a psychotherapy. Or they could be augmented with an augmentation agent, 2 augmentation agents or psychotherapy. And similarly for third and fourth treatment step. And as you can see that for these patients who ended up being augmented or with a second treatment, they did slightly better than those who got switched. With a very major caveat for you to remember, that is, this was done in an equipoise randomized design so that patients had a choice to make at that point. And so therefore, this group of patients would have agreed to go to an augmentation primarily because they were able to tolerate this treatment, or at least were willing to go along with it, and were wanting to try a second thing added to the first. This group of patients may have actually primarily said, I am done with this treatment, give me something totally different, and therefore these groups are slightly different in their clinical status, so we shouldn't automatically jump to the conclusion that augmentation is always better. But at least in this group of patients for whom augmentation was chosen, their remission rates are higher. The tragedy for depression treatment, and that is where I think why this topic is that important. I think that it is not only the short-term outcome that we should be thinking about. The long-term outcomes for this disorder are very troublesome. So this is for people who got well on the first treatment step. When you did a 1-year naturalistic follow-up, you can see a large proportion, even those who were in remission, about 30% of these patients, 33% of these patients actually relapsed. If the patient entered this long-term phase without achieving full remission, then the relapse rates were even higher. And then with succeeding steps, this is the most amazing, that at the end of second or at the end of fourth treatment step, they were in remission at the beginning of the long-term phase, and still their relapse rates were significantly high. So that means that the treatment of depression really should not actually be seen as a very short-lasting episodic treatment episode, but that we should be monitoring their long-term course and probably thinking about additional treatment approaches. There is also the other issue, and that is the field, the clinical practice has moved a little farther ahead from the data we had. So if you look at rates of combination antidepressants in the United States, this is from Mark Olfson's data, between 1996 and 2005 and 6, the rate of use of combination antidepressants in the United States doubled. So we have followed up that with a study trying to address the question is if you started patients on two combinations at the beginning and compared that to monotherapy, would that produce better outcomes, so to speak, stave off resistance in these patients if you were aggressive to begin with? Remember, the options were again using traditional antidepressant medications. And so here what we did was compared bupropion and escitalopram and venlafaxine and mirtazapine to escitalopram alone to find out whether a combination arm can produce higher remission rates if you start patients on it. So it is, I again want to emphasize that the pharmacotherapy they used was traditional, was nothing novel or different. And you find that remission rates are no different for people who are started on a combination as opposed to those who are started on a monotherapy. So at least with these antidepressant medications, you're not actually reducing or improving the chances of success compared to a monotherapy. So let me end by saying it is common and costly, and it does account for a fair high risk of morbidity and mortality for patients with treatment-resistant depression. And our options are, fortunately, that wasn't part of my presentation, but I think our options are still remain limited. Thank you very much.
Thank you very much, Dr. Trivedi. I'm going to actually call up Dr. Matthew Rudorfer, who's the program chief at the National Institutes of Mental Health.
Good morning. It's a pleasure to be with you this morning. This is actually my first MEDCAC meeting, and I've already learned 3 new acronyms. I have no disclosures to report, and the opinions I voice are my own, though I think for the most part they'll be reflected in the evidence. And to begin, I just want to note our discussion today will be focused on treatments of proven efficacy and effectiveness, but it is important to note that people continue to use a variety of interventions that are not proven and not tested. And one of my favorites, puppy licking your face, is a common augmentation agent, but I have no clinical trials to present. Now, I'm sorry for the busyness of this slide, but it tells a good story in one picture. This is to focus us on where we are right now in the treatment of late-life depression. This is from Chip Reynolds and his colleagues at Pittsburgh. They write, in general, the pharmacologic treatment of non-psychotic major depressive disorder in old age is only partially successful, with approximately 50% of older depressed adults improving with initial antidepressant monotherapy. If an initial antidepressant trial fails, the clinician has 2 pharmacologic options, just as we heard about in STAR-D, switch or augment on the one hand, or combine antidepressant therapies. About 50% of patients who do not improve after initial antidepressant therapy will respond to either switch or augment. If the clinician treats vigorously and if the patient and clinician persevere, up to 90% of older depressed patients will respond to pharmacologic treatment. Furthermore, electroconvulsive therapy, or ECT, is a safe and effective non-pharmacologic strategy for non-psychotic major depression that fails to respond to pharmacotherapy. Getting well and staying well is the goal. Thus, clinicians should treat to remission, not merely to response. So what I thought I would do with my time is present an overview of the study of depression with a skewing towards treatment resistance, a skewing towards older folks, and a skewing towards some of the methodologic challenges that complicate the interpretation of the data and will inform how we proceed from this point on. So I thought I'd start at the beginning, and I'm told that on Security Boulevard, the beginning of time is defined as 1965. With the birth of Medicare and Medicaid. Now, across the pond in the UK, some exciting things were happening also. The Beatles released their second full-length feature, Help, but we won't go there. But in the world of clinical research, this remains one of my favorite clinical trials, not to be replicated. This report to the Medical Research Council published in the British Medical Journal in '65, reported 250 hospitalized patients. These were not treatment resistant. This was pretty much standard, moderately depressed patients, many in primary care, and they were randomly assigned to 4 weeks of inpatient treatment with one of these interventions. One of the 2 standard pharmacotherapies at the time, imipramine, a tricyclic, phenelzine or Nardil, an MAOI, placebo, or ECT. Now, what's particularly fascinating here, first of all, I just wanted to note, because this is one phenomenon that has been lost to time, studies in inpatient samples are mostly a thing of the past. And of course, for many folks today, hospitalization is not cost effective, is much less frequently done than back in the 60s, say through 80s. And of course, a hospital stay today would be measured in days and not weeks. The advantage of a study done in an inpatient procedure, inpatient stay, is that on the one hand, it's a kind of screening for severity, if you will. If someone is sick enough to require being in the hospital for weeks, that usually indicates that their level of depression and level of dysfunction is quite severe, and existing treatments could often be safely discontinued, and new treatments started and given enough time to see if they will work. Also, the idea of randomly assigning people to ECT or any other active intervention is exceedingly hard to find in the decades since this was done. Now, for reasons that were not explained, in this first 4-week phase of the study, men and women were analyzed separately. There was a notable placebo response. Now, again, these were folks admitted to the hospital, which certainly probably contributes to that. The MAO inhibitor had some efficacy in the men, and for reasons that baffled the authors, it really didn't work at all in the women. Imipramine, the prototype antidepressant of the era, was nicely effective in the men, a little less so in the women. And of course, ECT blew the other treatments out of the water, which is especially striking, and I thought it's worth noting here, if you remember what Dr. Trivedi mentioned a few minutes ago, that again, these were not treatment-resistant patients. It's both a sign of the potency of ECT and a reminder that it's not necessary for many people to wait until they fail 20 treatments to think that maybe one needs to go beyond the usual pharmacotherapy. The other point I'd make about STAR-D, which Dr. Trivedi so nicely described for us, is that it really had a major impact on the field in introducing the concept of the stepwise treatment algorithm. That is, as opposed to taking each patient and trying to match them individually with an existing treatment, the idea was to go through a logical series of steps allowing adequate time and dosing at each, and then having pre-planned branch points. I'm sorry, this I realize is quite illegible, but I'll point out the key highlights. Ben Milsant at Toronto reanalyzed a couple of subsequent large clinical trials in late-life depression, also using a similar kind of treatment algorithm. He had the impact study with 3 steps, and prospect went to 6 steps. And an impact rate of response, which was defined as 50% reduction in depression score after 12 months, the step care approach using this kind of algorithm showed a 45% response rate compared to usual care with only 19%. And prospect, the results were a little less dramatic, but also significant in favor of using this kind of a STAR-D-like algorithm as opposed to usual care. Subsequently, these are practice guidelines, which I just want to call your attention to one or two interesting things. This is U.S. guidelines and Canadian next to them. Here's an item: what to do in case of partial response to an initial antidepressant. The U.S. says combine or augment with another agent, and the Canadians say switch. And I just thought that was interesting in that, as we saw with STAR-D, that's still an unsettled question and remains open to further study and often is still a matter of clinical judgment. Agents to consider for combination or augmentation, both guidelines agree that bupropion and lithium are good choices. Now, admittedly, this is from 2001, and the U.S. was still talking about nortriptyline, the tricyclic, and the Canadians, 5 years later, had dropped the tricyclic altogether and moved on to mirtazapine. I think that remains an interesting question for further consideration. That is, should we totally rule out the older classes of pharmacologic agents in treatment-resistant patients? Monsant came up with his own synthesis of the current literature, which looks like a kind of streamlined STAR-D, and I think that is pretty typical of today's clinical approach. Now, I just want to mention something about the different types of clinical trials, because as I think you've gathered already, not all trials are the same, and I find it particularly helpful in understanding the literature to appreciate the differences in methodology, which often can greatly influence the outcomes. So by efficacy, that's sometimes called regulatory trials, and it is an overstatement to call it yesterday, but these are the standard FDA-type active drug versus placebo studies, and these remain essential for proving that a treatment actually works. The dilemma, which even the FDA now acknowledges, is that generalizing from that to actual clinical samples can be a challenge when many of these trials are done in young, physically healthy white people, formerly men only, and don't resemble the actual patients being treated. And so that has led to the concept of effectiveness trials, which STAR-D is a perfect example of, where inclusion and exclusion criteria would be typically less stringent. People with comorbid conditions, maybe taking other meds for other illnesses, would not be excluded as they would be in an efficacy trial. And the important point there is that has to build on efficacy, because by the effectiveness stage, it's pretty much too late to see if something works, because if you want to see if it actually works, you do want that more homogeneous sample, but they work nicely sequentially like that. And I'll say something about where we're heading with clinical trials. And I said, well, the ultimate goal of personalized treatment, I think, remains a little bit beyond our grasp at the present time. Our former NIMH director, Tom Insel, has moved on to Google Health, so you know he knows the future. Now, he had this very nice description of experimental therapeutics as an approach to clinical trials, essentially introducing a translational aspect to clinical trials. That is, instead of just, here's a treatment, let's see how the depression rating changes, introducing a step in between to see that the intervention is actually engaging the target that's presumed to be the focus of the treatment, and that engagement is actually contributing to the clinical effect. In other words, trying to get at that kind of black box in between giving a medication and doing a rating. And this is still a new concept, and this is what we are now requiring of all NIMH clinical trials, so I hope that will inform us going forward. Dr. Trivedi mentioned some aspects of trials. I'll just skim over lightly, but I think that in reviewing the literature, there are a number of aspects beyond what jumps out at one that are important to consider, so that the way people are recruited to trials is not always obvious, but in recent years it's been noted that the placebo response rate in many trials seems to be creeping upward. And why could that be? One possible reason that's been put forward is that increasingly subjects are recruited not through clinical channels, but maybe through advertising, and are some of those folks less seriously ill to begin with and are less likely to respond to an active treatment, more likely to respond to placebo. Those are open questions. The comorbid conditions is certainly very important, because while comorbidities are allowed in effectiveness trials, you want to know about them so you can properly account for them. And I think the main message here is there are many aspects of subjects in clinical trials that you don't know unless you ask. And in many trials, if you're just kind of glancing through an abstract quickly, you might not appreciate that that the interrogation of the subjects might have been more or less comprehensive, and that can really influence how much you know about the people being studied. Similarly, all trials are not the same in terms of the treatment that is in the control condition. You know, you might be studying a new treatment or combination of treatments for depression, but as we'll see in a minute, even issues like the nature of placebo, the field has been arguing about probably going back to 1965. If you think about it, a group taking, say, a tricyclic antidepressant and another group taking a placebo, it wouldn't take, well, as Dr. Trivedi would point out, anybody's grandmother could probably tell the difference between a tricyclic filled with adverse effects and an inert placebo. So the field has argued for many years whether we need active placebos, and that really never caught on. Ratings, we know are important. The Hamilton rating is one of those instruments that's pronounced, it's pronounced dead and passé about every other year, and we're still talking about it. It remains the gold standard. Its primary problem is that it has a lot of focus on somatic symptoms, and if we get into the DSM at all today, you'll soon see that when we look at, say, DSM-5 criteria for major depression and the proverbial 5 of 9 symptoms, not everybody with major depression has the same symptom cluster, and there are folks who really have little in the way of somatic symptoms. And on the other hand, sometimes an immediate effect of a drug like sedation can have a disproportionate effect on the Hamilton symptom without getting at the core features of the depression. As we saw with the STAR-D trial, the QIDS has now become a standard alternative, and especially in European studies, the Montgomery-Åsberg scale, MADRS, has been very popular and is said to to better reflect changes induced by treatment over time. Now, in the efficacy trial era, the Hamilton score was the be-all and end-all, and now, of course, we're looking at other outcomes as well, as you see here, suicidal ideation and behavior, and all-important functioning, which is obviously key to relieving resistant depression, quality of life, and the interaction of mental health and physical health. Now, just one more point in terms of trial design. I put here screening tools such as the Patient Health Questionnaire 9, which is very common now in primary care, and rating instruments such as Hamilton, are not substitutes for complete history and diagnostic assessment. And I think that's really key because there are the occasional trial that can still slip into the literature where if you look at the inclusion criteria, it might say all patients met DSM-5 criteria for major depression, which is perfectly true, but totally inadequate because you don't know anything else. If all that happened was a research assistant stood with a checklist of DSM criteria. And so major depression can be a final common pathway of many conditions. It can be associated with all sorts of other mental and physical health issues. And even the very basic, as Dr. Trivedi pointed out, the very basic distinction between unipolar and bipolar depression can sometimes be missed and sometimes take some digging because if a person, say, has bipolar II disorder, they might well seek treatment for their depressive episode and fail to mention anything about hypomania unless they're actually closely asked about it. And similarly, we all are familiar that many relatively serious conditions, such as OCD, can be fairly silent if a patient or a would-be subject in a trial for an antidepressant is not asked about it. So a full diagnostic inquiry certainly is the state of the art. And I'll keep moving along. Along those same lines, we know that there are some useful subtypes of depression, and then there are some subtypes that haven't quite lived up to their reputation. So psychotic depression is one of them. Again, here, in many cases, this will be obvious, but if a person has, say, delusional ideas and is not verbalizing them, that can be easily missed. I'm thinking of a woman I once asked to sign a consent form for an ECT trial, and after she signed, I asked her what it was she had just agreed to, and she said, well, she just signed a confession to the police because she must have done something terrible. So this study shown here, Stop PD, and its follow-up, Stop PD 2, is specifically using the combination of an antipsychotic and an antidepressant. The real question is, how long do people need to stay on their antipsychotic? And again, as you can imagine, folks in a trial like this, you would not want in the typical treatment-resistant depression study that we're talking about, because it is very unlikely that you could expect them to respond to monotherapy with an antidepressant agent. Now, a couple of words about the switch and augmentation issues we've been discussing this morning. I think it's safe to say that on the whole, there's a certain amount of evidence for several approaches, and so this is different doses of quetiapine, the atypical antipsychotic. Again, these are depression scores going down in this 6-week trial compared to continuation of an only partially effective antidepressant, and a longer study with aripiprazole similarly showed that adding that atypical to a partially effective antidepressant certainly was effective. What we still lack is that personalization aspect to be able to predict for whom is this an appropriate intervention. Why not add lithium instead? We really don't know at this point. This was a nice recent meta-analysis showing 18 randomized clinical trials showing the effectiveness of atypical antipsychotics as adjunctive agents to partially effective antidepressants. What I think is particularly interesting here and does show how even though clinical trials can sometimes seem far removed from the clinic, they can provide very practical information. And that was the finding that low-dose atypicals actually were not effective, that it required full standard antipsychotic dosing, which might not have otherwise seemed obvious. Now, psychostimulants are, for many years, have been one of the kind of go-to treatments for older people, especially with many physical health challenges where docs were often reluctant to add an antidepressant to maybe to a complicated medication regimen. And there's certainly some evidence in the literature. I put this here really just to show in this relatively recent publication that we're still talking about case series and really not well-designed clinical trials. So again, there are a lot of treatments out there with really very varying levels of evidence. A new publication, Jan Fawcett and John Rush and colleagues, pramipexole, the dopamine agonist. This is also a case series. They did manage to collect 42 patients. So this we still need to take with a grain of salt. This is not a controlled trial. What I thought was interesting here on their idea of who responded. They talk about depressive episodes that are associated with severe anhedonia, lack of motivation, inability to initiate behaviors, and unreactive mood. Those are likely good candidates. That in one sense, it's a bit of a throwback to the idea of trying to match patients with treatments. It's interesting in that this is not a typical antidepressant, so I think that's certainly in need of further definitive study, but that's an interesting idea, I think, because it's something that the field has really been looking for some time. I just want to quickly go skim over devices because we could spend a whole day or longer on this, and maybe you have or will. I think it's safe to say that ECT, which here this is the unilateral electrode placement, which they undoubtedly did not use in that 1965 study, so that we do have more modern approaches to this old treatment. That ECT remains the gold standard for treatment-resistant depression. And there's a reason it hasn't gone away after after all these years, because nothing really has been able to replace it. As we're well aware, other device-based interventions are at varying levels of evidence. So no vagus nerve stimulation is on the market, and the field continues to discuss this. The acute results were disappointing, but there seems to be a later stage efficacy for some patients. And again, the nature of that response and for whom, I think, remains an unsettled question. Similarly, RTMS is on the market. It was actually initially improved specifically for early stage treatment resistance, so that has been loosened. It was initially defined as indicated just for folks who had failed one antidepressant trial, and now that's with the addition of multiple devices, that's been expanded. Interesting fact here is that, as I'll show you in a minute, the best large-scale trials were, by their very nature, efficacy trials, meaning they used RTMS as monotherapy. And the results, while significant, were less than startling, and leaving us with the question, well, but in real life circumstances, wouldn't you combine this with medication, or increasingly even people are trying to combine it with cognitive therapy? And so I think that, again, there are many open questions there. Deep brain stimulation, there are ongoing studies so far with mixed results in the literature. So ECT, just to make the point that in geriatric depression in particular, ECT has long felt to have a place in the armamentarium. Holly Lisenby published this review, 75% remission rate, which we're not used to seeing in psychiatry, and an effect size greater than pharmacotherapy. Now, to be fair, this was not based on random treatment assignment, like in that early British study. So people are carefully selected for likely response to ECT. A long-standing question was how to keep people well after they responded to ECT, and I think this remains an active question for many newer treatments under study, which seem to have a short duration of effect, and we've supported studies showing the effectiveness in some people of various forms of pharmacotherapy and continuation ECT, though even here there is a substantial relapse rate in the first year after response, so more work is certainly needed. This was just a recent study quantitating the speed of remission of ECT, which again, in some cases, would call for its use. This was specifically in older folks, but this kind of result would call for its use earlier in the algorithm than one might think of otherwise, so that an older patient, for instance, who is close to refusing to eat or drink and might be at very serious danger of physical harm, one does not need to say, well, we need to go through these 8 steps of the algorithm before we get to ECT. And a recently completed NIMH-supported trial prolonging remission in depressed elderly studied a novel form of personalized continuation ECT, whereby depending on weekly Hamilton ratings, a patient who had responded acutely to ECT could get 1 or 2 maintenance treatments that week, or skip that week altogether if they remained in good shape, trying to use the lowest effective dose, if you will. And another older slide, but unfortunately still relevant, this showed the distribution of ECT across the country. So high ECT rates are in black, and no ECT reported is in white. So this is the picture worth 1,000 words, and if anything, this is a 20-year-old survey, and I think it's safe to say, if anything, there'd be more white on the map today. And what's, I think, less often appreciated is that, especially as we talk about specialized treatments and even cognitive therapy could be included, that it can be surprisingly hard to find really well-qualified, well-trained practitioners, especially once you get away from the major metropolitan areas. I mentioned RTMS. This was the Foresight trial by Mark George that NIMH supported. So a remission rate of 14% with active RTMS and 5% in sham was significant, and again, obviously that one could say is less than exciting. To be fair, this was RTMS monotherapy. But the other interesting thing here that might be particularly important going forward was Dr. George and his colleagues spent a lot of time developing a sham version of RTMS, which has now become pretty well standardized in the field. And the idea being that one could hook up the patient to the device, put the electrode on the scalp, and have it actually heat up, vibrate, make noise, and for all the world seem like the real thing, only there's a metal plate blocking the magnetic waves from actually going into the brain. So that it's an ideal kind of sham device, which we're not used to seeing in psychiatry, because all these years it's really been difficult to do with ECT. There were about a dozen British studies a generation ago, but that's would be very problematic today, because sham ECT would require giving people general anesthesia and then not actually giving them a useful intervention. So I think ethically we would frown on that today. Among the issues of diagnosis, one phenomenon in older folks that's very easy to miss is the idea of complicated grief. And as you may know, the DSM committee struggled a lot with the so-called bereavement exclusion in depression, which is no longer with us. The point being that if a bereaved person has depression, then they should be treated for depression. A lot of work that we've supported, many done by Kathy Shear and her group at Columbia, has identified complicated grief, really unusually prolonged and disabling grief, which is especially prevalent in older women in their samples. And it's as if there's depression, to be sure, but with an overlay of what seems to be something akin to post-traumatic stress disorder. And so they've developed a psychotherapy that essentially took elements of both, took cognitive therapy and added some prolonged exposure components, as might be seen in treatment of PTSD, and have developed a very effective psychotherapeutic intervention. This JAMA paper from 2014, they actually, with complicated grief, compared to interpersonal therapy, which was very brave of them. There's a specialized psychotherapy for depression, but the response rate was double for the complicated grief therapy cohort. And they've just finished an NIMH-supported Foresight trial, adding in a pharmacotherapy option. So as you can see, these are cognitive grief psychotherapy and citalopram alone or combined, and we're expecting those results soon. My point here is that what is still unclear is whether folks who would be studied in this kind of trial would be included in a treatment-resistant depression study? And if so, would that influence the results one way or another? Again, I think it's fair to say that depression remains a very heterogeneous condition, and it is sometimes very tempting to overlook that in the interest of filling the cells in the study, but sometimes we can wind up diluting otherwise good results. Okay, the last item I want to cover then takes off from there in terms of the larger issue of where exactly does psychotherapy fit in the issue of treatment-resistant depression. And I think different approaches have been taken with different and sometimes slightly conflicting results. This review from 2010 was very frank. In terms of the utility of psychotherapy in managing treatment-resistant depression, evidence is sparse and results are mixed. And I think that that was very accurate. We tried to hone in on that with a couple of very specific studies. Revamp used a modified form of cognitive behavioral therapy called CBASP, Cognitive Behavioral and Analysis System, which was designed to treat chronic depression. And this was an interesting design of optimizing pharmacotherapy in people with depression, and then, if folks did not adequately respond, augmenting with either CBASP, this novel CBT treatment, or just supportive psychotherapy. And unfortunately, the results were disappointing. These were the non-responders and the partial responders, this being the Hamilton Depression Score on the y-axis. And essentially, you see these groups of 3 bars representing meds only, med plus CBT, med plus supportive therapy, and basically they were all the same. In other words, augmenting optimized medication with psychotherapy, even this highly specialized form of CBT, did not seem to make a difference. Now, back in Britain, they're looking at the effect of adding a U to behavioral. No, it's not just that. I don't know how they came up with cobalt, except unless they were just looking for a word that they could use CBT in. But this actually, Dr. Trivedi showed one of their design slides just showing the high incidence of treatment-resistant depression in primary care. And so they rounded up many practices to contribute to this study to see if augmentation of antidepressants with CBT could be effective. And I think what's particularly nice here, going back to one of Dr. Trivedi's early caveats, they had up to 5 years follow-up, which is very hard to find and very impressive. They did admittedly have a lot of blank space in between, but nonetheless, here this is 4-year follow-up, and they said, well, everybody seemed to improve, though nobody was perfect, but people who wound up on that combination fared better over time. And I just like this. They often have interesting turns of phrase across the pond, and I just like this. Good value for money. I thought a very direct observation that this was a very cost-effective intervention if it kept people well for 3 to 5 years. On the other hand, this study published in 2014 by a very stellar group of investigators has proven somewhat problematic. It's so problematic that in between the time I submitted the slide and today, they retracted the paper, but then they contributed a revised version of it. There was apparently some problem with the data analysis, but the results are unchanged. Here, in contrast to that Cobalt study where partial responders were augmented with CBT, here from the get-go, folks with depression were randomized to either meds alone or meds plus cognitive therapy. And again, just at the outset, these are very serious investigators led by Steve Holland, who certainly a leading investigator in CBT for depression. So you know that the treatment was very well provided. As a function of severity, these less severe folks, more severe. The lighter blue line, which is a little bit higher, showing greater improvement, was really not much different in the less severe group. In the more severe group, the addition of CBT from the outset did seem to make a difference. Now, just looking at the severe group, who as a whole did well with combined treatment, here we have the less chronically ill. And you can see here the kind of results that really were expected more or less across the board. These are folks treated just with meds. These are folks treated with the combination of meds plus CBT. And you could see recovery rate on the y-axis going notably higher with the combination group. On the other hand, the more chronically ill didn't make a difference. So they were left with this unexpected finding that augmenting antidepressants from day one with CBT seemed to be helpful, but only for some people, in the more severe but less chronically ill patients. And to state the obvious, that will require further study and replication, but I think it's a good illustration for us of how the field is not yet at the point of very clear-cut definitive findings. Michael Face did publish a very laudatory editorial, but to be fair, that was before the data problems were found.
Dr. Rudorfer, take about 5 more minutes, please.
So to wrap up, let me just point a little bit towards the future. You're probably all familiar with ketamine, so I won't go into that. A very nice acute treatment response, often seen within an hour, can last anywhere from a day to a week or so. And again, I think there the issues are sustaining that improvement. Just want to point out one thing as I wrap up, and that is increasingly the field is looking at components of mental disorders, including depression, as possible, on the one hand, building blocks of pathophysiology, and on the other, important to us today, as targets of treatment. And so here, just looking at the anhedonia item on in this case, the MADRS scale, anhedonia being obviously a key component of serious depression, you could see the response to ketamine. Similarly, suicidal ideation as a target of treatment unto itself has been gaining traction in some studies. Again, ketamine, here's ketamine in red, wish to live going up, wish to die going down. An experimental intervention, magnetic seizure therapy, which I thought was interesting, just in terms of that not depression per se, but the remission of suicidal ideation being the target of the treatment. You could read this in last month's JAMA Psychiatry. And one of the newest medications on the market, vortioxetine, that's Brintellix, has what appears to be unique data in terms of a positive effect on cognitive symptoms associated with depression. And they've been in discussions with the FDA seeking to expand their labeling, though I think that's taken a turn for the negative. And so we are trying to support this type of going back to basics, back to the building blocks of mental disorders, away from focusing narrowly just on the DSM categories with our RDocs project, which you can read about on our website. And on that note, I thank you for your attention.
Thank you very much. I appreciate the speakers' carefully designed presentations and also for being on time. So we're going to take a 15-minute break. We're going to start again at 10:13.
Everyone, we're about to start the scheduled public comments. I'd ask you to please take your seats so we can resume the session. Thank you.
You just did your vice chair.
Oh, okay. Well, thanks for advocating for nurse practitioners. The depression. They didn't give you the depression, right? They can help you with
Okay, the next section of the meeting is we have some scheduled comments. We have 8 speakers who are scheduled, beginning with Dr. Aronson. I'll ask that Dr. Aronson proceeds to the podium, and the next speaker, I think I see the chair, who's Dr. Sackheim, if you'd come and wait in the chair. One side note, out on the desk there is a list for people who would like to sign up to make open public comments, which we will do immediately after this. It's a brief period of 15 minutes. No one has signed up, which is, of course, fine. Don't feel pressured. But if you would like to make a comment, we're going to leave the list open. You need to fill out the disclosure form that is next to it. But if you'd like to do that, please do that in the next half hour. Anyway, so thank you very much, Dr. Aronson. You have 7 minutes.
Thank you. I'm Scott Aronson. I'm Director of Clinical Research Programs at Shepherd Pratt Health System in Baltimore and a Clinical Associate Professor of Psychiatry at the University of Maryland. I have these disclosures and I'll proceed to talk. Depression is a very serious disorder with significant morbidity and mortality. It's the leading cause of disability in the U.S., and 6 out of 10 Medicare beneficiaries under the age of 65 are diagnosed with a mental disorder, with mood disorders being the second leading cause of disability in Medicare recipients under the age of 65. Depression is one of the best predictors of the onset of stroke, diabetes, and heart disease. And any time it's comorbid with any medical conditions, it worsens the prognosis as well as the expense quite dramatically. People with depression are 3 times more likely to have heart attacks, and it's a stronger indication actually than hypertension. As well, a number of chronic conditions like asthma and other autoimmune diseases have a much higher likelihood in people with mood disorders. Every 13 minutes, an American dies by suicide, so we're counting up to 40,000 plus deaths per year by suicide. And 90% of these people who have committed suicide have a diagnosable psychiatric condition at the time of their death, and about half of those people who commit suicide are suffering from major depressive disorder. Mortality rates in Medicare beneficiaries with depression are similar to the overall population, but the age of death is about 11 years younger. The expenditures for patients with depression get added on to the medical expenditures. And while you see that folks with depression, you see the actual mental health expenditures are relatively small, they dramatically increase the total medical expenditures. And in general, if somebody shows up at a primary care clinician's office with 2 complaints of physical problems, they are twice as likely to have depression. For each additional medical complaint they have, you actually can sum up and say for 3 complaints, they're 3 times more likely to have depression. And even when you get up to 9 complaints, they are 9 times more likely to have depression. CMS recognized this in 2011 and decided to cover annual screening for depression. This is an important step forward, and we need to continue to have access for these patients throughout the continuum of care and for people with treatment-resistant depression. I think that staging depression should not be different than the staging of in oncology for cancers, where the more aggressive, toxic, or expensive treatments are reserved for the more severely ill. I think that's fairly easily translatable within psychiatry. Most of my research is, in fact, in treatment-resistant depression, using a variety of different agents as well as different somatic equipment. And I just want to give you some perspective about where the field is with regard to treatment-resistant depression. As an investigator for a number of different studies, we're very used to routinely staging patients, and most of the protocols that I do these days actually require pretty specific staging, that we have to evaluate the records of all patients coming into a study and determine their level of treatment resistance. We log basically every adequate trial of an agent, both in current and past episodes, and we calculate the severity of their illness based on these number of adequate medical and somatic therapies, and some trials as well include calculating psychotherapy. Increasingly, some of the studies, as the prior speakers have mentioned, are including suicide as a marker, which with some of the more recent agents like NMDA antagonists like ketamine become a particular target for symptoms. From the clinician point of view, I'm another one of my roles at Shepherd Pratt, which is a very large psychiatric teaching hospital, 330 beds and several hundred psychiatrists. I'm the psychopharmacologist of last resort. My colleagues know what treatment-resistant illness is, and I don't get called to see people who don't have treatment-resistant illness. The clinicians are never in doubt when they want an expert opinion. Patients, too, are very well aware when they have a treatment-resistant illness. It's actually easier for me to do studies that require me to find people with treatment-resistant illness than to just find standard people with depression who have not already been exposed to a number of agents. As well, my retention of patients in TRD studies is superior to that in just my routine studies, because these people are desperate. They want care. My retention rate for a study that was a 5-year study looking at people with an implantable device, our retention rate was 90% over 5 years. So we need to be able to offer these people something. I'm actually part of a triad of psychiatrists who will be presenting. My colleagues, Dr. Sackheim and Dr. Conway, will be addressing the more specific questions from the panel. And I also want to mention that the patient perspective will also be addressed in greater detail by Charlie Donovan. And thank you.
Thank you very much for your comments. Our next speaker is Dr. Harold Sackheim, who's a professor in the departments of psychiatry and radiology at the College of Physicians and Surgeons at Columbia and the Emeritus Chief Department of Biological Psychiatry, New York State Psychiatric Institute.
It's a pleasure to be here. Could we have the slides? Oh, there we go. I see them, but you don't.
Thank you.
That will induce treatment-resistant depression.
Oh, good. Now we have a definition.
Go. Okay, thank you. In terms of disclosures, I consult to a number of companies that work with brain stimulation devices as well as pharmaceuticals, and I'm the inventor of 2 forms of brain stimulation that are used primarily in treatment-resistant depression. The most common instrument used to assess treatment resistance across the world is the antidepressant treatment history form, which is an instrument we created in the late 90s, early 90s actually. And I want to highlight some features of it so that you get the sense of how reliably and validly we can assess treatment resistance. This is certainly critical to the definition of what treatment-resistant depression is. In clinical practice and in the world, we're going to see patients who have a treatment history, and so we're going to have to retrospectively evaluate whether or not their trials were adequate. That is opposed to prospective assessment, which occurs, for instance, in studies like STAR-D, where we see the patients de novo and we grow treatment resistance. The ATHF relies on multiple sources of information. It has explicit criteria, as you'll see in a second, for the dose and duration of interventions. The interventions that count are only those that count towards treatment resistance, which have established evidence regarding their efficacy in the treatment of depression. In making these judgments with the ATHF, one accounts for adherence and the outcome of the trial. So patients who do not adhere to treatment are not considered resistant in that trial. And patients who, for instance, benefit significantly and then the regimen is changed and they relapse, the original trial is not considered one that was failed. Each trial is rated on a 1 to 5 potency scale, with the threshold of 3 being what is considered to be an adequate or failed trial. And different criteria, different ratings are used for unipolar and bipolar depression, psychotic and non-psychotic depression, and so on, individualizing to some extent the evaluation of treatment resistance. To give you a sense, the evidence in the field is quite strong that patients with psychotic depression require combined treatment with an antipsychotic and an antidepressant. Antidepressants alone are not effective in that condition. So if a psychotically depressed patient only receives an antidepressant, that would not be considered an adequately failed trial. To highlight just the example, let's say nortriptyline, a tricyclic antidepressant, blood levels take precedence over oral dose at any time. If you take the drug for less than 4 weeks, you get the lowest score, regardless of the dosage obtained, or the blood level. Blood levels of 50 and above nanograms per ml reach the threshold of 3 for an adequate trial. And to get to the top score of 5, you have to have augmentation with a drug like lithium. Now, the ATHF has been applied in a host of contexts, and I'll just share with you very briefly a few examples. The first area was in regard to ECT. ECT has always been thought to be, in many ways, indifferent to the treatment history of the patient. It is our treatment, so to speak, of last resort, and treatment resistance now by the FDA is the leading indication for the use of ECT. Nonetheless, until 1990 or so, we had no data on the impact of treatment resistance on ECT outcome. These are from a randomized double-blind controlled trial at Columbia in which patients were assigned to 4 types of ECT, 3 types of right unilateral ECT, 1 type of bilateral. You can see that the forms of treatment differed in their efficacy. These are response rates to this treatment. But across the types of ECT, those who were medication resistant by the ATHF did less well than those who were not. In fact, with the most potent forms of treatment, high-dose right unilateral treatment, you get a almost 90% response rate in the non-resistant, and that drops to about 50% in the resistant. This explains both that treatment resistance even impacts on the efficacy of ECT, as well as the fact that ECT, nonetheless, among treatment-resistant patients is remarkably effective. Now, this phenomena has been sustained in meta-analyses. These are studies that have been done across the world, and what we can see is that degree of treatment resistance is associated with an impact on clinical outcome. So that this has now become an established phenomenon. Treatment resistance not only predicts whether or not you get well with ECT, but if you do get well, if you do remit, whether you're going to stay well. These data are from the first study of treatment resistance in depression, basically, and we were looking at a survival curve here of likelihood of not relapsing over a year period following remission with ECT, and we're comparing not TCA-resistant patients at that time to TCA-resistant patients, and you can see this big difference in propensity to relapse. This effect has been replicated in a number of studies. Here's another study from Columbia, in fact, that 2000 study that you saw the acute data from, and this is inadequate pharmacology before ECT, adequate pharmacology. So the treatment-resistant patient is both less likely to benefit from ECT and more likely to relapse if they do benefit, giving you a sense of the magnitude of the problem that we face, and the fact that the assessment of treatment-resistant obviously has important predictive validity. Some general observations. Typically, patients receive twice as many antidepressant trials as those that are deemed to be adequate. That there's a good deal of pseudo-resistance, and that's particularly true in the older patient population where they have greater intolerance of medications. Various studies have looked at what about treatment resistance predicts outcomes, whether we count the total number of trials patients have had, the potency score of each trial, or the number of adequate trials. It's the number of adequate trials that consistently has been predictive of future outcomes. And as you've seen in these data, treatment resistance is predictive of both immediate outcome and relapse rates. So it has impact on the long-term outcome of patients. In the studies, the ECT studies, about 2/3 of the patients were over the age of 65, and a large number were disabled. So it's obviously relevant to the Medicare population. To illustrate from another form of brain stimulation, this is repetitive transcranial magnetic stimulation, and these were the data that led the FDA to approve TMS for the treatment of depression. It was a post hoc analysis that was reported in the paper by Lisenby in Neuropsychopharmacology, in which patient group was broken up into those who had one adequate antidepressant trial, which they failed prior to entering the study, or more than one. And
please try and wrap up.
Sure. The difference with sham and active treatment was absent in those with more than one, and in one there was a significant effect. This predictive value of treatment resistance was replicated in our NIMH study of RTMS that I co-directed. Finally, a point that I'd make is if we look prospectively at treatment resistance, these are STAR-D data that Dr. Trivedi had shown earlier, where we're looking at acute remission rates at the different levels of STAR-D, likelihood of remaining well for a year following STAR-D, and if we compute something important, the probability of sustained benefit, both remitting acutely and remaining well. You can see at level 1, about a quarter of patients have a sustained benefit.
Dr. Sackheim, can you wrap up, please?
Yeah, but at the levels 3 and above, it sharply is reduced. Thank you.
Thank you very much. Next up is Dr. Charles Conway, Professor of Psychiatry and Director of the Washington University Treatment-Resistant Depression Center at the Washington University School of Medicine.
First of all, I'd like to thank Dr. Bach and the members of the panel for having this very important MEDCAC conference on the issue of treatment-resistant depression. As Dr. Bach mentioned in my introduction, I'm a professor of psychiatry at Washington University School of Medicine. I run the Washington University Treatment-Resistant Depression Center. My life's work is devoted to those who have treatment-resistant depression, so I feel very passionately about this cause. My disclosures, I have some research that's funded by the National Institute of Mental Health. I have research that's funded by multiple private foundations. I am here, I'm paying for myself to be here, so there's no one supporting me coming here. This is a slide, there's a lot of information on this one slide that I think is very important. This is a slide that is an empirical model of treatment resistance that the three psychiatrists, Dr. Aronson, Sackheim, and myself put together. This is a model in which we present a workable, empirically based model of treatment resistance based largely on the STAR-D trial. As Dr. Trivedi mentioned in his opening talk, to some extent, at this point in our knowledge of treatment-resistant depression, we could say with some certainty that there is a turning point, typically, as was observed in the STAR-D trial, right at the level of 2 adequate dose duration failures. What I think is important, and Dr. Sackheim just brought up this point, was that after you failed 2 adequate dose duration trials, not only is your probability of responding to a third trial poor, but your probability of sustaining a response drops significantly, such that at this point here, you could safely say that individuals who fail a third adequate dose duration trial of an antidepressant have about a 5% chance of being well at 1 year. So in other words, this is pretty clearly a point of treatment resistance, and we would offer to you, the panel, that the empirical evidence clearly supports that this is a point at which we need to begin thinking about novel treatments. One of the things that Dr. Sackheim and others have demonstrated is that stimulation therapies and other types of therapies actually seem to have better staying power than do medications in terms of this resistant population. These are the types of treatments that we need to think about supporting in a research operational definition of treatment-resistant depression. Now, if you look at this as similar to a model of cancer treatment with a stage 1 and a stage 2, the treatments, as Dr. Aronson pointed out, the more invasive treatments, things that involve implanting devices into people, should probably be saved for those who have more severe treatment-resistant depression, similar to a cancer model where a more severe cancer would get more severe treatment. Okay, what I'm going to do in the next 6 slides is go through each of the individual questions that the panel asked and give the consensus of our group and the field in general, I think, supports the evidence I'm about to present. So the first question was from the panel, in defining treatment-resistant depression, should the number, dose, duration, and classes of antidepressants be included? The answer would be yes, 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 no. The number, dose, and duration, that's information that's provided in the STAR-D trial, and that information pretty definitively indicates that there is a point where you can determine treatment resistance. Antidepressant class, probably not, because the current evidence suggests that different antidepressants are equally effective in depression, with perhaps some exception of MAOI inhibitors. Augmentation strategies and combination strategies, as the STAR-D data demonstrated, they do also represent adequate antidepressant measures, or should be included in a characterization of treatment-resistant depression trials. The type of depression, obviously this topic could be, you could give a 45-minute talk on it, but the answer is yes, the type of depression is very important. For all intents and purposes, we have the most study that's been done so far, and the most evidence that's present is for unipolar depression. That was what the STAR-D trial did. The other types of depression, such as psychotic depression, bipolar depression, as the slide indicates, the treatment for those is very different. And because of that, we're proposing in our treatment-resistant depression operational definition that this should be only for treatment-resistant unipolar depression. The other types of depression are equally severe and have their own issues, but I think for the purposes of this operational definition, we need to focus on unipolar depression. Should ECT be a mandatory part of an operational definition of TRD? The answer, we believe, is no. You should not have to have ECT. No one should be required to have ECT in order to meet the operational definition of treatment-resistant depression, despite the fact, as Dr. Sackheim pointed out, that it is a critical part of our treatments for TRD. Psychotherapy, yes, as was pointed out by Dr. Rudorfer's talk and others, psychotherapy does play a central role in managing treatment-resistant depression. It should be included as another treatment trial in terms of determining efficacy. In terms of should we use standardized scales to treat and to measure response in treatment-resistant depression, the answer would be yes. The scales, there's a whole diversity of scales, the Hamilton, the Madras, and others that were mentioned. But we believe that there should be a minimum score, but that we see a lot of patients with long-term mild to moderate depression, so it's not a single one-size-fits-all. Suicide is a huge issue in TRD, as was pointed out by other speakers. Last week, the CDC issued a statement indicating that over the past 10 years, the suicide rate has grown 1% in the first 5 years of that 10-year study, 2% for each year in the second 5 years of that study. So a significant proportion of those patients who are committing suicide have treatment-resistant depression. So I think the critical importance of this is huge. So where should we study treatment-resistant depression? We would argue that the best place to study treatment-resistant depression is probably in psychiatric clinics. And the best place, we believe, to study treatment-resistant depression is in clinics with expertise in treatment-resistant depression, or centers of excellence, similar to models that have been used in other areas that CMS has done research in, where you establish centers that have expertise in treatment-resistant depression. And there are many of these centers throughout the country that have been involved in treatment-resistant depression studies for years. Finally, my last slide, in terms of what is the best way to study treatment-resistant depression? Well, the answer depends on what you're trying to get at in terms of the study. In most studies, we prefer to use sham-controlled, double-blind, placebo, prospective trials, but there are other good methods of studying treatment-resistant depression. In closing, I would like to make this remark to the panel. This issue, the decision that you're going to be making this afternoon, I think, is very, very critical and is going to affect thousands, tens of thousands of people's lives going forward. And I think some of the people who are going to follow me up here are going to speak eloquently about how treatment-resistant has affected their lives of family members. This is a very real illness, and we need, as a field and as a country, I think we need to do more for these people, and what we're doing right now, I think, is inadequate. So thank you very much for your time and attention.
Thank you very much. Dr. Stephanie Fox-Rawlings is next. She's a senior fellow from the National Center for Health Research. Dr. Fox-Rawlings, you don't have any slides, is that correct?
No. Thank you for the opportunity to speak today. My name is Dr. Stephanie Fox-Rawlings. I was previously a neuroscientist at the Children's National Medical Center, and I'm now a senior fellow at the National Center for Health Research. Our research center analyzes scientific and medical data to provide objective health information to patients, policymakers, and providers. We do not accept funding from the drug or medical device industry, and I have no conflicts of interest. A standard definition for TRD would be beneficial to patients, prescribers, researchers, and insurance companies. A Medicare definition for TRD could have a widespread impact. Unfortunately, definitions for TRD in clinical trials are diverse and some do not make sense. For example, the definition used by some studies of TMS and other devices is a failure of just one prior treatment. One treatment failure is not uncommon and should not be considered treatment resistant. A definition that balances the need for identifying most patients without being overly broad could improve our knowledge of which treatments tend to work and for whom. Providing a better definition for TRD would reduce the number of patients incorrectly given the diagnosis. A recent review by Marzek found that most patients diagnosed with TRD may not be. This could be due to inaccurate or incomplete diagnosis or to insufficient treatment duration or dosage. It can also be caused by limited access to affordable or effective mental health services. About a third of misdiagnoses are due to non-adherence of treatment. This could be caused by cost, social, environmental conditions, or side effects. Stricter guidelines for TRD would help control these confounding variables, helping to identify whether a treatment works or not. It is important to reduce barriers to compliance because after multiple treatment failures, patients are less likely to achieve remission and more likely to try treatments with more severe side effects or less clear efficacy. A definition for TRD would also need to address the issue of how to define remission and to describe what constitutes a sufficient and adequate treatment trial. It would further need to include the number of treatments, trials, and their types. Inclusion of specific types of therapy in the definition may increase the likelihood that they are attempted. Many patients defined as having TRD may never have tried cognitive behavioral therapy, although it can be effective. Patients may not know where to find a therapist or have heard of it or prefer medication. Medicare defines TRD as a condition for people who have tried and failed several types of therapy, including cognitive behavioral therapy. It could influence patients to try it. A recent review of TRD studies found that only about 15% of patients reported suicide ideation and 17% had a previous suicide attempt. Either TRD was not appropriately defined for these studies, or a definition requiring either suicide ideation or attempt would inappropriately exclude many TRD patients. To be useful for clinical trials, a definition for TRD needs to take into account that depression waxes and wanes for most patients. Randomized studies with placebo and sham treatments are essential for differentiating between treatment efficacy, depression's cyclic nature, and the strong placebo effect. Medicare analysis of the efficacy of a particular treatment need to include randomized, blinded, and placebo or sham-controlled studies. Clinical trials should include men and women, as well as sufficient numbers of racial minorities and patients over 65. Many treatments have not been analyzed to ensure that they are both safe and effective for patients over 65 and older. Metabolism, eating habits, and activity levels change with age and can affect the way a treatment works. Similarly, some treatments do not work as well for certain minority groups or for both men and women due to cultural or biological reasons. Clinical trials should focus on clinically meaningful improvements in patients' lives. They should include improvement in the ability to function and in quality of life. For those that have suicide ideation or suicide attempts, a decrease would be beneficial, but this is not relevant to the population as a whole. In conclusion, a clear, well-constructed TRD definition for Medicare would benefit patients. Treatments should be evaluated in terms of improving daily life functioning and quality of life. Decisions concerning the appropriate treatments for TRD should include well-controlled randomized trial, including men, women, minorities, and patients over 65. Thank you for your time and consideration of our views.
Thank you very much. Next up is Charlie Donovan, and Mr. Donovan, you do not have slides either?
No, sir. No. My name is Charles Donovan, and I am a mortgage banker in St. Louis, Missouri, employed by Mortgage Solutions of St. Louis. Livanova paid for the travel expenses that enabled me to be here today. I have no other disclosures. I appreciate the opportunity to speak to the panel. As the panel deliberates today on an operational definition of treatment-resistant depression, an estimated 120 people will commit suicide. And tomorrow, another 120 people will commit suicide. And according to an alarming report issued last week by the Centers for Disease Control and Prevention, 41,000 people in the United States commit suicide annually. Many of these suicides are the result of the hopelessness that comes with TRD. I feel like I'm in a unique position to speak to you about treatment-resistant depression. 12 years ago, I wrote a book on this very specific topic of treatment-resistant depression. The book, entitled Out of the Black Hole, chronicles my personal struggle with the disease, the seemingly endless search for a solution, and my emergence from TRD thanks to the pioneering treatment of vagus nerve stimulation. Since that time, I received countless letters and emails from desperate TRD patients seeking a solution to this terrible disease. In their communications with me, virtually all of them say the exact same thing, that they had read their own very personal story in my book. I struggle as to how to share with the panel what life is like to live with major or resistant depression, so I needed only to consult the book that I had written 12 years ago. I could only read a few pages. I was shocked and appalled by the very words that I had written. It took me back through my journey into the black hole of depression. It was about as ugly a story as one would ever want to read. Unfortunately, it is a story shared by many TRD patients. Speaking to the panel about this today is not easy for me. Nobody rings a bell when depression starts. For me, it began in my teens. Over the ensuing years, the episodes came back with greater frequency and severity. I suffered my first major depressive episode as a senior studying in the business school at Georgetown University, ironically not far from where we are today. Day after day, month after month, I suffered from absolutely debilitating depression. I greatly feared that I would be unable to graduate. Eventually, I did recover, but it was a battle. After graduation, I moved to New York to begin a career on Wall Street. Within a few months, the depression returned, and I started on a 20-year merry-go-round of antidepressants, augmentation strategies, tranquilizers, and psychotropic drugs. I have always had access to the very best that our healthcare system had to offer, including highly skilled and experienced psychiatrists and psychotherapists. I've been so fortunate to have benefited from the guidance and expertise of some of the leading clinicians in the country. We tried absolutely every treatment modality possible, but nothing worked. By age 39, I had tried 15 different medications, ECT, seen 8 different psychiatrists, had countless psychotherapy sessions, and been hospitalized 4 or 5 different times. I just gave up on living. I was unable to work. I isolated myself from friends and family. I suffered from terrible agoraphobia. I could not concentrate enough to read a book, follow the plot of a movie or television program. There was no happiness or joy. Isolation, social withdrawal, despair, and hopelessness, these are all common symptoms of TRD. And I'll just deviate from my statement. The previous presenters talked about the costs and expenditures related to TRD. I have to believe the direct cost to treat me during those 20 years was in the hundreds of thousands of dollars. In 2001, by a stroke of incredible good luck, I found out about a novel treatment for TRD that was undergoing early studies, vagus nerve stimulation. Mostly out of sheer desperation, I considered entering the double-blind, placebo-controlled clinical trial. The research psychiatrist who happens to be here today said to me that there was an inkling that there might possibly be something to this novel treatment. And I said to myself, inkling? I'll try it. I was so desperate to try anything new, I had nothing to lose. The day before the procedure, I simply told the clinical researchers that I wanted to die on the operating table. You cannot sink any lower than that without committing suicide. The therapy ultimately completely changed my life. In 2005, vagus nerve stimulation received FDA approval for TRD. 11 years after FDA approval, TRD patients still do not have access to this potentially remarkable, life-saving, life-altering procedures. Many authors who write memoirs about a disease or a challenge that they have overcome conclude their stories that they are grateful for what they have learned from their experience. As I conclude, I can tell you, I am not in any way grateful from my horrific experience with TRD. TRD patients often suffer in silence. I hope that I have given these patients a voice here at today's meeting. The healthcare system has failed this desperate patient population for many years. I strongly urge the panel to do everything in its power to rectify this terrible injustice. The determination of a reasonable definition of TRD is a beginning to the development and the approval of new treatments for resistant depression. Thank you.
Next up is Andrew Sperling, who's the Director of Advocacy, National Alliance on Mental Illness.
Thank you. I have no slides. It's difficult to follow that very moving statement. Thank you for that courageous effort to be here today. Thank you. So I'm Andrew Sperling with the National Alliance on Mental Illness. NAMI is the nation's largest grassroots organization representing and advocating on behalf of people with severe mental illness, including treatment-resistant depression. You've heard certainly from Dr. Trivedi and Dr. Rudorfer and the other witnesses, the enormous public health burden associated with treatment-resistant depression, the enormous risk of suicide. Few people know this, but mortality from suicide now in the United States exceeds mortality from both breast cancer and prostate cancer. The public health burden is not just the treatment of the disorder, but the enormous risk that people with treatment depression have to getting comorbid chronic medical conditions, and because of their depression are unable to manage those comorbid chronic conditions, and it actually leads to early mortality from those disorders as well. The diagnostics are an enormous challenge, and I think Dr. Rudorfer, Dr. Veli talked about that. We have to move beyond the current diagnostics and move toward RDoC. That's why the important work that NIMH is doing has to go forward. We have to get beyond measuring the severity of symptoms. And if we're going to move forward in really developing disease-modifying therapies for this very serious disorder. What is critical, NAMI's main takeaway from our presentation today is that CMS, not in this panel, this MEDCAC panel, do nothing to limit access to any FDA-approved therapy for treatment-resistant depression, and do not develop any strict criteria that would apply to any particular therapy before patients can access those therapies. Let me briefly go through the questions that are presented to this MEDCAC panel. Number one, in terms of defining treatment-resistant depression, I think Dr. Trivedi and Dr. Rudorfer provide you with strong evidence that there are well-established definitions of treatment-resistant depression out there. And NAMI would question whether it's CMS's job as a payor to define what treatment-resistant depression is. The research needs to drive that question, which is precisely why the important work that NIMH is doing on RDoC to develop newer and better diagnostic criteria has to move forward. And CMS as a payor establishing a static definition of treatment-resistant depression is not the way to go. You need to allow the science to evolve and advance and on that particular question. Number two, the defining characteristics. All of those listed in the question should apply. Unipolar versus bipolar, augmentation therapy, use of psychotherapy, suicidal ideation, suicidal depression. All of these characteristics should apply what is really a very heterogeneous population, particularly within the Medicare population, which brings us to question number three, how to apply this definition in Medicare. You have to recognize the heterogeneity of people, Medicare beneficiaries with treatment-resistant depression. People think of Medicare as being the elderly, the senior citizen health care program. There are more than 6 million non-elderly people with disabilities that qualify for Medicare but as a result of getting on SSDI. This particular cohort is more likely to have treatment-resistant depression because they've met a definition of disability that they are so disabled they can't work at any job in the American economy at what's called substantial gainful activity, a little over $1,000 a month. So you're more likely to find a concentration of people with treatment-resistant depression that got onto SSDI in that population. You have to recognize that they are going to be seen largely in this specialty behavioral health care setting, very, very different in how this is diagnosed and treated in the elderly population, where it's more likely to be with a geriatrician or a primary care doctor who first diagnosed, and they're unlikely to end up in that specialty behavioral health setting over time. Number four, what are the reliable, valid outcomes for Medicare beneficiaries? I think all of the things that are listed there, both functioning, quality of life, suicidal ideation and attempts, the outcomes we get with this population, I think we've heard over and over again from Dr. Rudorfer, Dr. Trivedi, and others, are pretty grim. Suicide, greater risk of comorbid chronic, poorly managed comorbid chronic medical conditions. We need a whole slew of outcomes that CMS ought to be looking at in terms of what we think outcomes ought to be and advancing on treatment-resistant depression. And then finally, the realistic study designs. Obviously, randomized controlled trials remain the gold standard, but we have to advance beyond that because many randomized controlled trials have exclusionary criteria that will leave the most severely ill patients out of certain randomized controlled trials. So previous history of suicidal ideation or suicidal attempts, it's very difficult to study treatment of depression when you say if you've had any suicidal ideation or any previous history of suicide that you're excluded from a randomized controlled trial. You are not going to get the answers to the question you need for real treatment-resistant depression using exclusionary criteria. So you should be very careful with that. And then in conclusion, again, the panel should not, this panel, CMS, should not be using this to in any way limit access or place barriers in front of existing FDA-approved therapies for treatment-resistant depression. These patients and their families are desperate for answers, desperate for advances, and CMS needs to keep that in mind. Thank you very much.
Thank you very much. Next up is Eric Scharf, who's the Advocacy Advisor for the Depression and Bipolar Support Alliance.
Thank you. It's good to be here today. Again, my name is Eric Scharf. I work as a volunteer with the Depression and Bipolar Support Alliance. In terms of disclosure, they did pay my reimburse me for travel today. I have a written statement. There's also been a more in-depth statement provided to you also from our national office. Unlike any organization of its kind, DBSA is created and led by individuals who themselves have a mood disorder diagnosis, with our bylaws which stipulate that over half of our governing board of directors and the paid professional staff must be people who have or had depression or bipolar disorder. Therefore, this first-person lived experience informs everything we do. I personally live with TRD and receive Social Security disability benefits. Prior to my TRD diagnosis, I was the owner of an association management and consulting firm. During my career, I served as executive director of 4 different membership associations and worked with many others. During that time, I worked at a professional level. I often describe my current situation as going from 8 cylinders to 4 cylinders, often just not having the energy to focus on the work like I did previously. I have tried countless medications with little or no success. Today, though, with the help of my Social Security benefits, which has provided me with some sense of financial stability and new life skills and medications that help me to treat some of the symptoms that I experience, I'm able to lead a life of meaning, but lacking with the level of energy and excitement that I once felt. It's a very frustrating situation to be in. DBSA's vision is wellness for people with mood disorders, and we believe that an open and collaborative approach to treatment that accounts for the whole person, where she or he is right now, is what allows people to achieve what they personally define as wellness. Our collaborators include a scientific advisory board made up of the nation's leading clinical and research experts on mood disorders. We are nationally recognized for peer support training services and weave those with the lived experience of mental health conditions into the fabric of care as adjunctive providers of education and support. Ultimately, we at DBSA believe that our balanced, person-centered, wellness-oriented approach is what has allowed us to educate, empower, support, and inspire individuals to achieve the lives they want to lead for our now 30 years in existence. Moreover, these 3 decades of peer-led work have enabled DBSA to coalesce a strong base of active participants. In fact, through the more than 700 in-person peer support groups provided by DBSA's network of 300 chapters throughout the country, along with our printed and virtual education resources and wellness materials, DBSA reaches over 3 million people per year. As the foregoing hopefully illustrates, DBSA's 3 decades of representation of and engagement with people who have mood disorders has put DBSA in a unique position to assist MEDCAC as they seek to define treatment-resistant depression and to provide guidance on how to conduct studies for treatment options. Overall, we believe that meaningful innovation in treatment will be aided by understanding, first and foremost, how those receiving the treatment define success, rather than simply relying upon the assessments of clinicians and researchers. Along these lines, the following are the 5 most important areas that DBSA asks you to consider when providing guidance. 1. Efforts to improve definition and measurement of success from the perspectives of those who live with TRD, much like some of the folks who have spoken already. For the people who live with TRD, the past 25 years has seen anemic progress in the development of meaningful new treatments. Innovation has been incremental. People are consequently frustrated by and losing hope for a solution. Modest improvement in clinical outcomes are simply no longer enough. Of course, the first priority for treatment is ensuring that a person living with TRD is provided a pathway out of crisis and onto stability. However, all too often, this baseline stability is also the end goal established for successful long-term care. Stable or better is not always synonymous with well. DBSA believes that every person deserves the opportunity not just to survive, but to thrive. And to do that, we need to ensure true wellness as the end goal for TRD treatment. Consider this. The successful treatment for cancer targets the removal of every cancerous cell, the achievement of complete remission. We, DBSA, believes that measures of treatment efficacy need to evolve. Changing measurement tools to include wellness outcomes as defined by people with TRD would greatly improve treatment, for example. MEDCAC could recommend elevating the importance of existing clinical measurement tools that address function, such as the Sheehan Disability Scale, or that address wellness, such as the WHO-5 scale. Both are useful in allowing not only for the mood-related improvements necessary by achieving complete wellness, but also the interpersonal and relational aspects of individuals' experience with TRD. 3, DBSA participants with TRD look to MEDCAC to increase consideration of the whole health implications of interventions with TRD symptoms. The weight of TRD negatively affects people with co-occurring conditions, which are frequent and diverse, ranging from diabetes to cardiovascular conditions to cancer. Treating both TRD and any co-concurring conditions, recognizing and allowing for their complex interrelationships is imperative to achieving optimal outcomes. DBSA urges MEDCAC to consider implications of chronic versus episodic experiences. Success should not be defined by controlling this week's, month's, or even year's episode, but by reducing the severity and eliminating the reoccurrence of symptoms over the entire lifetime. This is not often the defined objective for clinicians or researchers, but it is of vital importance to people experiencing TRD as well as their families. Finally, DBSA notes that payers, including the Centers for Medicaid and Medicaid Services, hesitate to include novel treatments for depression. The current measures and criteria for determining that a new treatment is safe and effective do not answer payers' questions about whether a new treatment offers benefit over existing treatments and whether these added benefits justify an added cost, because payers tend to resist coverage for new treatments, and inadvertent disincentive for research and development exists. DBSA supports your initiative around TRD. We sincerely hope that with the committee's work, we will promote an environment that supports the development of better treatment options and encourages exploration of the steps that need to be taken in order to break out from the current dynamic of incremental, slow improvement to one of exciting breakthroughs. Part of this depends upon a transformation of the way we currently measure success. We urge the committee to look for guidance from those living with, to bend the focus of scientific discovery towards the things that matter the most to all of us. Thank you for your attention.
Thank you very much. Next up is Dr. Brian Olin, who's the Vice President, Quality and Regulatory Affairs for Cyberonics Incorporated.
Thank you for having me here. Oops. As mentioned, I'm the Vice President of Quality and Regulatory for Cyberonics, a division of LivaNova, and as such, my disclosure, I'm an employee and a shareholder of the company. What I'm going to start talking about today is addressing question 4, which has to do with the outcomes measures to really assess the degree to which patients improve under treatment. And the question deals with, it provides a number of different outcome measures, and I'll mention that all those outcome measures that are provided within that question have been successfully used in both in pre-approval trials for drugs that are now are approved by FDA and covered by CMS for treatment-resistant depression, as well as trials for devices that are done that were approved and in some cases covered by CMS. These are all validated measures. They have all been well characterized throughout the literature. And as you know, as you probably saw this morning in several of the physicians' presentations, they were featured prominently in many of these trials. From the standpoint of the quality of life and patient functioning measures, I've listed several of those below there. MADRS, Hamilton Depression Rating Scales, and a couple of those are actually patient-rated scales as well, which provides kind of a unique perspective of the patient's self-assessment of their improvement as they're moving through the treatment continuum. I'll also note that a couple of the questions that are one of the concepts was looking at suicidal ideation. And 2 of those particular scales and many others like them, the HAM-D, the MADRS, and then also the IDS as well, have an item embedded in there that speaks to suicidal ideation. So that allows us to actually measure longitudinally over time how the patient is progressing with respect to that. And then finally, CMS's and HHS's own databases allow us to extract and have some sense of suicide attempts around psychiatric hospitalizations, medical hospitalizations, as well as utilization. And these all will help give us a good sense of how that patient is doing on these treatments. The second thing what I'd like to kind of conclude with is also as we transition now from the speakers discussing, providing their perspective into the MEDCAC panel deliberation, I'd like to provide you with some background on a similar situation in which the MEDCAC met over a decade ago to consider a situation that has a lot of striking parallels with the question that we're covering today. And that was namely the MEDCAC's consideration of the use of bariatric surgery in morbidly obese population. And they're shared a lot of very striking similarities there in terms of what that MEDCAC panel had to discuss. They had to grapple with uncertainties around definition. They had to grapple around a population that had a lot of the evidence base, had a limited experience in the traditional Medicare population. Many of those patients in that evidence base were in their 30s, their 40s, their 50s. They were entering Medicare through disability as opposed to age. There were the same types of morbidities were present in that patient population. Joint issues, hypertension, metabolic disorders. Those are also present in the TRD population that we're discussing today. Likewise, in terms of how do you measure success and outcome, that was very patient-dependent as well, too, in those considerations. And there was a staged approach to care. So MEDCACs before have had to grapple with these types of difficulties, and were able to successfully do that to find a way to come up and allow coverage of appropriate therapies for patients with this disorder. Further showing some of the similarities between this population, one of the measures that has been used many times to assess patient functioning and quality of life is the SF-36. And what you see here is a direct comparison of obesity population, patients that are subjected to bariatric surgery, and in the lighter blue bars, the darker blue bars, patients from an early pilot study on patients with TRD that were treated with VNS therapy. And what you notice is strikingly in a lot of the physical function domains of the SF-36, these patient populations are very comparable. But But very clearly, when you get to the mental health functioning, the patients with TRD are much more lower functioning and much more severely ill. So again, very similar patient populations until it comes to the mental health aspects of this. So this is a bit of a sort of a detail, more details on the specific comparisons here. But again, I think the really important things here around, again, the difficulties with coming up with a common definition. And I think as we've seen today throughout the discussions that each of the physicians have had, there's some common themes around duration, around severity, around the number of prior treatments that have been failed that are very, very consistent threads in the definition of TRD. And there were similar threads within bariatric surgery. Likewise, there's very clear ways to measure them. There are a variety of different ways. It's a matter of selecting the ones that are most appropriate from an evidence development. I provided some on the previous slides. I discussed the population issues and the morbidity issues. I'll conclude with the treatment issues. Again, bariatric surgery in morbidly obese patients, just as with TRD that we're considering today, it's very important to consider an individualized approach to treatment and to make sure that the appropriate treatments are available for that individualized approach to take place. And again, I think that is really crucial. And the other aspect is both have a staged approach to care. And both in that stage approach to care, as discussed by Dr. Rudorfer and others, had to do with looking at the individual benefit risk for that patient at that point in time in their disease progression. So what I'd like to conclude with is a few people have discussed a pressing need to really look at one of those specific treatments for patients with treatment-resistant depression, and that's vagus nerve stimulation. And in the context of the definition that we're discussing today, the FDA-approved indication features many of the items, if not all of the items, that were discussed by our speakers today in terms of failed medications, prior severity, the chronicity of the disease. It's well proven and tried throughout clinical trials. There have been a variety of randomized trials that have been conducted on this, whereas even in some of the prior MEDCACs, the decisions for coverage decisions were made without any RCTs and without the same level of evidence base. And what I would conclude with is, based on this discussion, this panel can provide patients with this additional option while simultaneously developing evidence that can help answer some of the open questions. There are appropriate study designs to be able to address this. There are appropriate means by which we can classify patients as TRD or not. As others have talked about, there exist experienced centers to do this, similar to the TAVR situation that CMS has approved, to make sure people get the proper treatment. And finally, I just talked about recommended outcome measures. Those exist, and each of those can answer the open questions that remain about this and provide a roadmap for future therapies. Thank you very much.
Thank you very much, Dr. Olin. That concludes our scheduled public comments. Despite us leaving the sign-up list open longer, apparently the rest of you have no interest in speaking to your government. So no one signed up, which means first we're going to break for lunch early. Everything in the agenda is now 15 minutes earlier. But let me just say thank you to the 10 speakers this morning for your organization, for your thoughtfulness, for your focus. I think you've done a great service to the panel and to the topic collectively and individually. And everyone enjoy your lunch. What?